Thank you for the organizing committee for inviting me. Thank you, Professor Hisham, Professor Adel Itribi, and all the organizing committee from Ain Shams University on behalf of the Egyptian Society of Cardiology Working Group. I will take your permission to present a non-live in a box case because we managed to do the 6-month follow-up of 2 cases of thrombus. So I could not put it in the live in a box, so I put it in a presentation. We just changed it. But I will present very briefly during the allotted period of time 3 cases of thrombus in STEMI, which all happened in 2018 and which were managed in different approaches, trying to stick to the guidelines. The 2017 ESC guidelines for acute myocardial infarction in STEMI patients has put some interesting stuff regarding thrombus management. One of them was that the use of the routine use of deferred stenting has now become red. So all this business, all our colleagues who look at an artery and then see a thrombus and then say agrastat and second look are now in this red zone. You can't do that in STEMI. If you cannot deal with thrombus inside the cath lab, then please don't take your STEMI patients to the cath lab, because by definition, most of them have thrombus, and some of them will have very large thrombus. So if looking at thrombus will scare you, then just give them thrombolytic or send them to somebody who's not scared of thrombus. The second issue with the guidelines is that we have now 2 class 3 indications. One of them is that routine use, and that is not use, it's routine use of thrombus aspiration is now not recommended, that's class 3, and routine use of deferred stenting is not recommended. So you can still occasionally use aspiration, you can still occasionally defer, but you cannot routinely do this. Our first case is an accountant. He's 52 years old, he's non-smoker, he's dyslipidemic, he's hypertensive, with a very strong family history of coronary artery disease. He got chest pain, it was inferior. He did not present himself to a hospital except 72 hours later because his pain went away and then came back. He came in the evening with the evidence of right ventricular involvement with hypotension, with ongoing chest pain, and elevated ST in the infralateral leads. He was taken to the cath lab straight away and a radial sheath was inserted. This is actually pictures which I took after the PCI, because the left system before the right PCI was non-selective, but it just shows, because you can see the stent here, but it just shows, sorry, you can see the stent here. Anyway, it just shows the الماوس مش بيتحرك كويس. It shows a totally occluded circumflex, which some people might have thought was the culprit, and it shows a small LAD. Here you can see the LAD. It's not reaching the apex and it's not very healthy. And there are some, this is his RCA. So we are working radial. We had a look at this patient's RCA, and in an inferior STEMI situation, late presenter with ongoing ischemia, which will kind of piecemeal infarction. And we can see a filling defect with our naked eye. Sorry, here is the filling defect. So this is another view. And you can see that there is another lesion, a tight lesion before the bifurcation, and the lesion containing the thrombus, the culprit lesion, is proximally. Everybody can see that, and it's a dominant RCA in a patient with an occluded circumflex and a small LAD not reaching the apex. So that RCA is a very, very important artery. So who would proceed to PCI and who would defer to give agrastat? You know, I don't need a show of hands, but just think about it, if anybody would. So anyway, we put the wire in, and I want you to notice what happened to the thrombus. This is just by wiring. Just by wiring and angiography, at least half the thrombus has moved and is embolized and is now here. Okay? So we have thrombus here and thrombus here. And we have a tight lesion here. Okay? So what would you do now? Who would proceed to PCI? Again, who would defer? Your patient is in actual infarction, so you need to do something. So anyway, this is an aspiration catheter. I thought I'd get some thrombus out. The aspiration catheter, if you notice, did not cross this lesion, and it pushes the guide catheter out. So we take a picture after aspiration, and the thrombus, which was in the middle of the artery, has now moved distally and has got caught in the lesion, which was here. It's stuck in the stenosis. It's a piece of chewing gum which is flying about. So I decided to pre-dilate the proximal lesion because the thrombus aspiration catheter did not pass, and I didn't think that the stent was passed. And I can tell that at the bottom here, the thrombus is still stuck here and is occluding the contrast material. And then we stented the proximal segment with a large stent. And we can see the staining of the thrombus of the part down here. After the stent, no reflow. Patient very, very symptomatic. So what will you do?
دكتور هاني ايه الشادو التاني دوت البارallel؟
That's the thrombus. Staining of the contrast with the thrombus. Here? This?
اللي فوقيه
Yeah, it's just thrombus. And possibly thrombus in small vessels. You'll see it now, Professor. So anyway, this is a trick which I've been doing for many years, which I learned from Said Gizi, my colleague, which is to go in with a balloon, a deflated balloon, and scaffold the thrombus in no reflow. If you get distal flow, then you can stent. You can stent the thrombus, because it means that when you put mechanical pressure against the thrombus, you can actually see flow. The cine before that shows no flow. I now put a balloon in and I can see flow, okay? My wire, I want you to notice, is in the posterolateral branch, not in the PDA, and I'll explain that in a minute. So I decide to stent. I dilate this lesion, I dilate the thrombus, and then I put a long stent. This is the stent before deployment. The simple presence of the stent is causing TIMI3 flow, because it's opening a track in the thrombus. And now you pray, you can only pray, that when you put the stent, the thrombus is not gonna dislodge. So we deploy the stent. You never go to extreme pressures, but you go enough to see the stent well deployed, and you get a TIMI3 flow. So you deal with this thrombus, and sorry, I need to, the mouse is, الماوس باد ده ثمنه 5 جنيه، يعني كنت تقول نجيب واحد. ماشي. Okay, so anyway, I put another wire because I wanted to open the stent to the PDA. This stent was open towards the posterolateral. And I put a balloon in, and I did that. I put a balloon on the bottom wire, and I opened the stent struts into the PDA, and this was the final result. The patient, of course, was put on 2B3A blockers and nitrates, and this was the final result of the primary PCI. You can see that this RCA is collateralizing the circumflex, and it is completely free of filling defects with very good TIMI flow. This is after removing the wires. The patient has been asymptomatic for 6 months now. He's got a normal left ventricular function. He was sent to SPECT for assessment of ischemia and the LAD in the circumflex areas, so we can decide if he'll need further revascularization. This is patient number 2, who was done in March this year.
Dr. Hany, for
Yes.
patient number 2.
Sorry?
What about the antithrombotics intracoronary in this situation?
Sorry, sir?
Antithrombotics intracoronary, integralin or agrastat or...
Yeah, he was put, all during the procedure, he was on 2B3A blockers. He was on ticagrelor, loaded before the procedure, and aspirin, and he's being kept on ticagrelor and aspirin. But the 2B3A, which was used peri-procedurally, was only continued for 8 hours post-procedure. After the end of the first ampoule, I did not repeat it. And he was radial, we were not worried about bleeding. Patient number 2 came in March this year. He's a 48-year-old diabetic. At the time, he was a heavy smoker. Now he's a non-smoker. He was smoking 60 cigarettes a day, who had recently lost weight due to major gastric weight loss surgery. He had lost more than 60 kilograms. He came with an anterior STEMI. He was in a board meeting in a Heliopolis hotel, and he called me from the board meeting saying that he has severe chest pain. We both arrived in hospital at the same time, and from the first medical contact to wiring his LAD was less than 20 minutes. The patient was moved from the ambulance to the cath lab. He was in near cardiogenic shock. His systolic blood pressure was 75. He was alert. An echo, bedside echo done on the cath table showed major left ventricular hypokinesia, and he was very tachycardic. He was extremely irritable, and I decided to go femoral, which is against what I usually do. We just took one picture of his RCA. We knew that the culprit was his LAD. We then put a guiding catheter and took the first picture of his LAD. We could notice that there was a tight circumflex lesion before the bifurcation in this view, and decided to see it in a better view. But anyway, this is his LAD. It's occluded. A BMW was put, and aspiration using a 7 French compatible export catheter was done immediately. In spite of retrieving significant amount of thrombus, we still had poor flow. Please note that now you can also see a diagonal. Can you see the diagonal with the slow flow outside the wire? Because this diagonal is interesting. We'll see it in a moment. So now we have this LAD, which is full of thrombus, which is horrible. You can see the filling defects all the way. By the way, this is the thing in his stomach. They call it the stomach ring or something. His gastric, his weight loss surgery. You can see it. It's annoying, but I can't do anything to get it out of the picture. And you can see the thrombus as it crosses this tube in his stomach inside the LAD. Again, 2B3A blockers were started on table inside the room, including an intracoronary bolus. We pre-dilated the lesion, the culprit lesion. The patient was not doing well on table. His blood pressure was very low, and he was suffering with pain. And if you can see, there is thrombus all over the place. I decided to stent the proximal lesion. I probably should have used the 4mm stent, but I used the 3.5 by 23 Zynes stent because of the data on Zynes in primary PCI. It was taken to 14 atmosphere. And please note that there is a diagonal. Can you see the diagonal? The LAD now has major improvement in flow. There was no LAD before. And it's full of filling defects. And you can see the big one is where the LAD crosses the gastric tube. And you can see the diagonal which is filling, and its ostium is completely full of thrombi. The patient at this moment starting to get better. You can see as the LAD turns round, and now you can't see the diagonal if you notice. The diagonal is gone. The diagonal is gone. The patient has some chest pain, and it's my decision now what to do. So this patient is full of thrombus. A huge LAD has been opened. The patient is coming back from cardiogenic shock with major left ventricular stunning, at least on echo. You can see the filling defects, and the diagonal is gone. And there's a lot of thrombus in the LAD. At this point in time, my colleague said, let's go for the diagonal. I decided to move the patient to the intensive care unit on 2B3A blockers. After 48 hours on tirofiban, enoxparine, ticagrelor, and aspirin, we brought him back and went radial this time, and the diagonal is back. You can see it, it's huge, and it's filling TIMI3. The LAD is filling TIMI3, and you can see the very critical circumflex stenosis. We're following the guidelines of doing the complete revascularization inside the index hospitalization, but not during cardiogenic shock. You notice the diagonal is back. You can see the filling defect. Let me try and play this again. Okay, I'll take it back. The diagonal is back, and you can see the filling defect in this ostium. And the question is, would you do it now, or is it healing? Just leave it alone. I was wanting to do the circumflex, so I decided to leave the diagonal alone. If you notice, most of the thrombi in the LAD are gone. The LAD is clean now, and it was full of thrombus. We decided just to do PCI on the circumflex with a 3.5 15 Zine stent. It was pre-dilated actually, but I didn't want to waste your time with many, and it was an excellent outcome. The patient was sent home. Please note resolution of his LAD thrombus and reappearance of the diagonal without an intervention. He spent 6 days in the CCU. His left ventricle improved to near normal before discharge. It was a very quick improvement. He returned to his hypertensive status on day 1 post-PCI. He was known hypertensive, was put on maximum dose of beta blockers and ACE. We managed to put this patient on captopril 150 milligrams before we discharged him from hospital because he was hypertensive. Hypertensive heart failure is a blessing when you want to increase the doses. After enrollment in a professional rehab program in Egypt at 6 months follow-up, the patient, who's a non-smoker, exercises for 1 hour daily under supervision and is doing really well. His left ventricular ejection fraction is 54. He has mild apical hypokinesia, no mitral regurgitation. I'm happy to say that I called him yesterday because he gets very happy when he knows that his case is being presented, and he's doing extremely well. He's traveling to the United States, and I'll see him next week. This is my last patient, which I did
before
last
going
week.
to the third case, I think this is an example of the wisdom of knowing when to stop and when to proceed. Of course, we have this visual reflex whenever we see a stenosis or a thrombus, we go in and jump to do everything in front of us. But sometimes, especially in acute situations, as you did here, you did the perfect job. You stopped, you just opened the LAD, which was very necessary, but you did not go to the diagonal and you did not waste time. And because sometimes when you overdo things, the patient may arrest and die. So I think this is a clear example of doing the right thing at the right time. And then you went back. Maybe we can argue regarding in the second setting whether we can also tackle the diagonal or not. But anyhow, I think at the very beginning, when you stopped and you just finished and did the LAD, put the patient on 2B3A and waited for 48 hours, I think this was an excellent decision at that time.
Thank you. On the second, when I was doing the circumflex 2.5 days later, I had the IVUS machine, and I was seriously considering looking at the LAD stent and post-dilating it with a 4mm balloon. I had an impression it was slightly undersized. But because I knew that there was probably some thrombus behind it, and because of the thrombus in the ostium of the diagonal, and because of my joy at the patient's course, I did not want to overdo it. But it's still a concern that I have that the LAD stent, even though it's 3.5, may have been a little bit undersized. And this patient, I'm hoping at some point, if he agrees, to recath, just to have a look and see, make sure that everything is all right. From this patient, really, as I'm telling you, came back from the brink of evolving cardiogenic shock. I think what saved him from cardiogenic shock most of anything was his extremely early presentation. From the time he was in an airport on the outskirts of Heliopolis, and from the moment he got the chest pain till he was in hospital, it took 40 minutes because I looked at my mobile and I could see, I could really time him. And from the moment he came to hospital, he did not go to the intensive care. He came straight to the cath lab. We did everything on the cath table, including the echo. And from his arrival till the wire was in the LAD, it was 20 minutes. So the entire pain to wire in the LAD was about 60 minutes. And yet this patient had major thrombosis and shock. So sometimes it's possible that thrombus can develop very quickly. And we were lucky. And as you all know, a lot of us are working now, including with Khalid Chokri and Professor Adil, on the trying to implement this for all of us, because all of us, everybody sitting on this table, myself, most people in this room except the young ladies, are liable to develop a STEMI. And we don't know what, I don't know what I would do if I get a STEMI at 3 o'clock in the morning. I'll probably call one of you, you know, but there's no clear pathway. If we can get clear pathways, we'll all get this kind of management.
But we know that 1/3 of the patients do not even reach the hospital.
They die.
They die in the first hour or two. So it's a great save.
Thank you. My third case, which I did 10 days ago, is a very interesting case because, again, I followed the guidelines. This is a patient who came 5 days post-inferior infarction. It was unfortunately missed. And his treating physicians had told him that it was a gastrointestinal symptoms because he really has no risk factors, okay? He's a very healthy young man. He had, by the time he came, he had an inferior STEMI on his ECG. He had no more chest pain, and he had mild inferior wall hypokinesia. So this is a diagnostic angiogram from his right radial artery, and it shows a totally occluded thrombus-filled RCA very, very proximally. Here is his RCA. Now, if you look at his left system, this young man obviously has some genetic issues because he has severe ectasia, he has severe atherosclerosis, non-occlusive lesions, a lot of near aneurysms in his arteries. But interestingly, look at the RCA filling from below. He's already got decent collaterals to his RCA. I took several views of his left system from his radial artery, and you can see the PDA filling at the bottom. I sent him to Professor Itribi's excellent dobutamine echo center, which is probably the most experienced in the country. And he had a high dose testing by our colleague there, Professor Zainab, who's extremely experienced. And I called her and she said, he has zero ischemia. He has no ischemia, no residual ischemia, because I was very keen to open him. During those 10 days, I only did him about 10 days ago, and then I recathed him the day before yesterday. During those 10 days, I kept him on Enoxparine 80 milligrams twice daily, ticagrelor and aspirin, and I was hoping that so after the negative dobutamine echo, the patient said, he's 39 years old, so he said, what do you think? I said that if you would allow me, I'd like to do a diagnostic angiogram free of charge. I just want to have a look and see what happened to your artery, if it is open or not, and this was on exactly 10 days of enoxaparin, ticagrelor, and aspirin. You can see that, of course, there's no distal flow, although actually I'll show you that now the distal RCA is also getting, I'll show you the next view, is also getting some antigrade flow from collaterals, but at least half that artery has opened. And you can see how horrible the artery looks, how ectatic, how full of thrombus, and you can anticipate that if you had put a wire in unnecessarily, because the guidelines say that this patient who comes after more than 48 hours is class 3 for routine revascularization. And you could have probably killed this patient with no need to even revascularize him at all. Look at this second view, look at his RCA, and look at the distal filling, which you're going to see now. You're going to see at least some branches. You see the posterolateral branch up there. And of course, we've got the excellent collaterals from the left system. So this patient has a near normal left ventricle, he has a dominant RCA, and we have negative, non-invasive proof of ischemia just 15 days following his STEMI. And the question is, who would routinely open him? I decided to stick to the guidelines. I reassured the patient, and I said that possibly his artery might even, we did a blood picture, and he does not develop any heparin-induced purpura, so I asked him to stay on the anticoagulant for a few more days. I'm not going to recath him again. If he remains asymptomatic, we'll just leave him as is. If he ever develops symptoms, then it will probably be easier to do his RCA at some point than it was on day one. So I'd like to conclude by saying...
ثانية واحدة ما نسألك بس هو دفع يعني في القسطرة دي ولا دفعش بس شباب؟
Yeah.
القسطرة دي ها؟
Sorry?
He paid for the angio ولا ما في؟
No, the second angio is a gift. Because I really wanted to do it, it was not indicated. It was not indicated. When I want to do a follow-up angiogram, which is not indicated, I explain to the patients that they're just doing it for the service of science. But, you know, if I had put a stent, he would have paid.
طيب.
It was just diagnostic.
Wouldn't you put him on rivaroxaban, 2.5 milligrams twice
I'm
daily?
actually, thank you very much. I'm actually planning to put him on triple therapy. I might remove the aspirin, but my plan for this patient, and I told him that, is actually to put him, as I'm going to say it now, on ticagrelor and on dabigatran 150 milligram twice daily, based on the redual PCI trial, which actually showed that those two extremely potent anticoagulant and antiplatelet are safe without aspirin in select patients. He's 39 years old. He has very low has-bled score. He has no, and we did both procedures radially, and now I'm keeping him on heparin. He's going to shift from heparin to dabigatran 150 milligrams. And, you know, I might even angio him again in a few months' time.
But why not 2.5 rivaroxaban twice daily?
I think the rivaroxaban...
It's a class 2B indication. But
you're right. But I think I don't want to use it for its, I want to use it for its full anticoagulant function. I mean, this RCA to me looks like a vein graft, or like, I'd really like to use an anticoagulant. If this was before the days of the NOACs, probably Professor Galal Said would have even recommended giving this patient warfarin. I want to give him the most potent anticoagulant that there is. But I'd like to conclude by saying that in case 1, I had an older organized thrombus in the RCA due to the late presentation. Aspiration was not useful. The thrombus embolized distally, not because of the aspiration, just embolized with the wire. It did cause no reflow, followed by TIMI3 flow and TIMI3 blush after stenting both the culprit lesion and stenting the thrombus in the distal lesion. Case 2 was a different case. All these patients were acute myocardial infarction. Case 2 was after establishing TIMI3 flow in life-threatening scenario with extensive anterior STEMI happening in the LAD before the first diagonal, before the first septal, and with massive thrombosis despite very early presentation, very early primary PCI. The patient was managed in the CCU with anticoagulation 2B3A blockers. 48 hours later, brought to the cath lab completing the circumflex. There was major resolution of the intracoronary thrombus with restoration of TIMI3 flow in a large occluded diagonal without intervention, as you saw. Case 3, as per the guidelines, a totally occluded infarct-related artery should not be routinely opened after more than 48 hours. And our case shows that the people who put the guidelines are wise, because this patient has no ischemia on the abutamen echo. And this patient would have been subjected to an unnecessary risk and unnecessary cost had we decided to open it. The 3 cases show different techniques of successful management of large embolizing thrombi in primary PCI settings in a variety of late, early, and very late presenters. Thank you very much.
هو كان في اقتراح سي تي انجيو بلاش، بس انا رفضت.